Hi, I'm Jane Meisel. I'm a medical oncologist at the Winship Cancer Institute at Emory University, an assistant professor of medicine here at the university. I specialize in treating breast and gynecologic cancers. It's a challenging question because I think a lot of people think immunocompromised means a lot of different things. I think of it as, especially in the context of our cancer patients, if you're on a treatment that maybe depletes your white blood cells or decreases your ability to mount an immune response to an infection. I think that's the most, kind of critical and relevant piece when it comes to thinking about COVID-19. Most patients who have active cancer, their immune systems are a little bit compromised just fundamentally by having the cancer itself. And we know from early data that's come out of China and other places, that patients who have cancer tend to have worse complications from COVID-19 than patients who don't on average. So we do want our cancer patients to be extra cautious, thinking about things like social distancing, obviously frequent hand washing, and then if they have to come into the hospital or the clinic for treatments or evaluation, just to make sure that they do so as safely as possible. And I think all the cancer centers are really trying to make every effort to make sure the patients are safe when they walk through our doors. That everything is sterilized and sanitized, and that all of our staff are following appropriate social distancing regulations and making sure to keep our patients safe. It's a challenging question. I think a history of cancer, not necessarily. I have a number of patients who are breast cancer survivors, out 10 or 15 years, who are fine, who have said, am I at increased risk? And I think, if you had an early stage cancer that was cured years ago, probably not so much. If you have a history of cancer and you've received recent chemotherapy or radiation therapy, then you do have a little bit of an increased risk just because your immune system is a bit compromised by those recent treatments. And I think any patient who's actively undergoing cancer therapy, either in the curative setting or for metastatic disease, probably falls into that category of patients where we want to be a little bit extra cautious. I think, patients who are on oral cancer therapies make up a growing percentage of our patient population with disease. And I think, for a lot of these patients, we're accustomed to seeing them, more frequently than we maybe critically need to during a pandemic. And similarly, checking labs maybe more often than we critically need to during a pandemic. So I'm having conversations, really kind of complex risk-benefit conversations with each of my patients on oral therapy about, during this time, how often do you really need to be coming in and checking labs and seeing me? Or, given if you've had a history of stable labs on a particular oral therapy for several months, might it be okay for you to skip a month of lab work and do a telehealth visit, and do labs later on, or do labs closer to home and see me via telehealth? So I think, certainly making sure that patients on oral therapies do know to be in touch with their doctor if they're having any changes in their health or any complications, especially if they've made arrangements to see their doctors less often during this COVID-19 pandemic. But also really having conversations about how often they do need to be coming in, so that they're doing everything that's safe for monitoring their progress on oral therapy, but that they're also, not coming in when they don't absolutely need to be. One too, and I think it gets at this whole risk-benefit conversation, and really every conversation that we have with cancer patients about starting a new treatment has a risk-benefit analysis inherent in that. What are the patient's underlying risk for complications from that therapy versus what is the risk of cancer progression or cancer recurrence if they don't pursue that therapy. And I think, having COVID-19 in the balance just adds another layer of complexity to that risk-benefit discussion. So I think, there are some patients for whom a potentially planned course of treatment could be postponed without a lot of negative impact on the patient, and that may potentially make them safer, especially if they have comorbidities like poor lung function or obesity or old age, and make them someone who might be likely to really suffer if they were to contract the virus. And then there are others for whom they may be young and healthy, but for an aggressive cancer, and they really need to start therapy for that aggressive cancer before they become symptomatic. And in that setting, I would err more on the side of starting the treatment immediately. But I think, there's not one right answer or one particular answer to that question. I think it's just a question of really talking about the risks and benefits with that patient and assessing where they are. There are particular situations of breast cancer where a patient might ordinarily undergo surgery first for, say, an early stage estrogen-sensitive breast cancer. But now in the setting of COVID-19, a lot of us are giving for those strongly estrogen-positive, lower-grade cancers neoadjuvant endocrine therapy first, like tamoxifen or an aromatase inhibitor, to kind of bridge them to surgery. so that patients can be on some form of active therapy for their cancer, but not one that causes a lot of issues, in order to delay a planned surgery to a time where it's a little bit more safe, we think, to be in the hospital. Again, I think it's probably worth a discussion with your doctor because the answer may be different depending on the kind of cancer you had, how far out you are from your cancer, and anything else. I think for a lot of patients, if you have had no evidence of cancer and you have no symptoms or signs suggestive of recurrence at this point, many of us are delaying those repeat scans until wherever we are in the country sort of peaks in terms of the pandemic and things start to get safer. But again, I think that's a question probably for each patient to discuss with their doctor, just because the preferences regarding that may change a little bit based on each patient's